Good morning. So I'm going to present in English. So I'm going to present a randomized controlled trial of treatment with intermittent negative pressure for intermittent claudication, which was published in Norway. So, brief introduction: intermittent claudication is the common symptoms in patients with peripheral peripheral arterial diseases. So, as a non-surgical treatment for those patients, we have the exercise therapy programs that increases the walking capacity, along with the cessation and the pharmacological therapy have been proposed through the years. However, the availability of these exercises program is low, and some patients they are either unwilling or unable to participate. Consequently, different devices and different treatment have been proposed. So we have the intermittent negative pressure. So the treatment of cough or food using the intermittent negative pressure has been also suggested to improve the walking distance for patients with intermittent claudications. So it's basically it increases the arterial blood flow acutely, which might increase the arterial shear stress and inducing flow-mediated vasodilators. So with the intermittent negative pressure, as we mentioned before, however, if optimum treatment is now well established, several studies have come up with different outcomes. So it's mostly related to the treatment intensity or the duration of treatment, which was varies among different studies. So, what's the objective of this randomized controlled trial? To investigate the clinical effect of treatment with negative 40 millimeter mercury of intermittent negative pressure for 1 hour in the morning and 1 hour in the evening for 12 weeks in patients with intermittent claudications. They hypothesized that treatment would improve the pain-free walking distance and maximum walking distance compared with the sham control group.
Mohamed, I have a question. What is this device? It's an external device, internal device. What it looks like exactly?
I'm gonna
you're gonna.
I'm gonna mention the device. Wait, this one.
Okay.
I'm gonna go back. So I'm gonna talk briefly about the device. Before that, I'm gonna talk about the methodology. So the type of the research is a multi-center prospective randomized controlled trial enrollment of patients. So they enroll the patients at the vascular surgical clinics, 3 vascular surgical clinics in Norway from January to September 2019. So basically, patients were randomized 1-to-1 ratio. So to the two groups. So we have the treatment groups, which they gave negative 40 millimeter mercury, and we have the sham control group, which they gave negative 10 millimeter mercury of intermittent negative pressure. So the device, okay. So what's the device? What's the intermittent negative pressure protocol? So basically, they use a machine pump, a machine device that has been sealed to the patient leg, and with a pump unit that producing or that gives a 10 seconds of negative pressure and a 7 seconds of atmospheric pressure. The device is it's made in Europe, and they use the Otivo also in Oslo, Norway. I'm going to talk later about the company of the device. So all patients were instructed to treat themselves at home for 1 hour in the morning and 1 hour in the evening for 12 weeks of treatment. All patients were trained to use the device before the start of the treatment. The daily treatment was recorded by the device for the analysis later on. So what's the inclusion criteria and the exclusion criteria? As for the inclusion criteria, we have patients either with the ABI of less or equal than 0.9, or patients were diagnosed with the radiological findings of the peripheral arterial diseases and with the symptoms of intermittent claudications. They were assessed for with the eligibility. So as for the exclusion criteria, if we have patients that has been scheduled for surgery or they have been undergone a surgical revascularization with the previous 3 months, they were excluded. So patients, if they cannot perform the treadmill test for assess the efficacy, they were excluded. if the patient they cannot independently operate the treatment device, they were also excluded. And patients with severe heart disease and chronic obstructive diseases, they were also excluded. And patients who have at the beginning of the treatment of the maximum walking distance of more than 1,000 meters, they were also excluded. And at the end, if patients they cannot perform a consent, they were also excluded. So what's the outcome of this randomized control trials? We have 5 outcomes, and we have the 2 primary outcomes. So we have pain-free walking distance. We have maximum walking distance on a treadmill. We have the resting and post-exercise anchor-brachial index. We have resting and post-ischemic blood flow. And we have at the end the quality of life. It was basically a questionnaire. The patients were filled out at the beginning and after 12 weeks of the treatment. All patients were given the full base medical therapy according to the European guidelines. So assessment, how they assess the outcomes. So the pain-free walking distance and the maximum walking distance were measured by the patient walking on a treadmill by using a certain protocol, which is a RAM protocol. The patients, the treadmill, it ran at a constant speed of 3.2 kilometer per hour, starting at a 0 slope and increasing by 2% every 2 minutes. Resting and post-exercise ABI was measured at the patient's spine positions. All patients were requested to complete the quality of life questionnaires at the beginning and after 12 weeks of treatment. Analysis. As for the analysis, differences within the group were analyzed by using the pair sample t-test. Differences between groups were evaluated by using univariate analysis of covariance. As for the p-value, less or equal than 0.05 were considered significant. So the results. So at the beginning, we have 85 patients were assessed for the eligibility. For the inclusion and exclusion criteria, there were 13 patients were excluded. They did not meet the inclusion criteria. So as for the randomization, we have 72 patients were randomized to the treatment group and to the control group. And as for the follow-up, we lost 6 patients in the treatment group and we lost 3 patients in the control group. So at the end of the 12 weeks, we have 32 patients in the treatment group. They were available for analysis. And in the control group, we have 31 patients. They were available for analysis.
It's not exactly loss of follow-up. I mean that we know what happens with this patient, so it's not really loss of follow-up. That's fine.
D'accord. Okay, so the demographic variables. So as for the demographic variables, we have the age, the male, and we have the comorbidities. What's interesting is that the prevalence of diabetes was higher in the patients in the treatment group. So we have 18 patients with the prevalence of diabetes. In comparison, we have 6 patients with diabetes, which was a significant difference. However, among all other variables, there were no significant association between the 2 groups. So we can move on. Okay, so pain-free walking distance, which is the main finding. So at the baseline, the pain-free walking distance was 109 meters on average for the treatment group. And for the control group, we have 111 meters. That was at the baseline. So after 12 weeks of the treatment, we can notice that a significant change has been occurred in the pain-free walking distance of the treatment group of 68 meters. So the red point is the treatment group and the blue point is the control group. So the treatment group, a significant change has been occurred of 68 meters on average, and the control group, we have 18 meters significant change has been occurred. Both of them they were significant, a p-value of the 0.001 and a p-value of the control group of 0.064. So the between group comparison showed that a significant changes of the pain-free walking distance favoring the treatment group with the sham group. Sham group is the control group, and the p-value of 0.014, and the confidence interval 11 to 89, and the treatment and the estimated treatment effect of 50 meters. So I'm gonna move on to the maximum walking distance. So as for the maximum walking distance at baseline, we have the maximum walking distance of the treatment group was 267 meters on average. And as for the sham group, the control group, it was 263 meters on average. And after 12 weeks of treatment, we can notice that a significant change has been occurred of the treatment group of the 62 meters. However, a non-significant change has been occurred to the for the control group of 20 meters. So in between group comparison showed that no significant differences in the changes of the maximum walking distance for the two groups. So we have the p-value of 0.14, and that was not a significant change. As for the other variables, we have the ABI and the blood flow measurements and the quality of life. We did not notice any significant changes for these variables. I'm gonna move quickly. So they did the so that's for the maximum walking distance. Yeah, this okay. So they did a subgroup analysis of patients with the pain-free walking distance of less than 200 meters. So at the beginning, we had the 63 patients. So patients who presented at the beginning of pain-free walking distance of less than 200 meters, they were sub-analyzed. So we had 56 patients who presented at the beginning of pain-free walking distance of less than 200 meters. They did the analysis with the same variables. They did find that there were significant changes in both the pain-free walking distance and the maximum walking distance favoring the treatment group. So we have this table. It's mentioned that the pain-free walking distance and the maximum walking distance of the 56 patients, with the p-value of with the changes of the significant p-value of the 0.042 and 0.032, and estimated treatment effect of for the pain-free walking distance 42 meters, maximum walking distance is the 62 meters. However, for the other variables, they were not significant. So, brief point, to the best of the author's knowledge, the presented study is one of the first double-blind randomized controlled trial to show that intermittent negative pressure treatment increases the walking distance for patients with intermittent claudication. So why the author, they did choose the negative 40 millimeter mercury was the standard for the device. The device provided by this company, the Confit European market, FlowOps, which is commercially available in Europe. As for the measurement of the pain-free walking distance, a small bias that might have been occurred because the pain is a subjective report. So in the patient being observed by the evaluator, they might have been reacted differently to the pain, and they did not evaluate that probably. So in regards to the quality of life, so this study, the presented study, did not find any significant changes of the quality of life parameters across the two groups after the 12 weeks of treatment. However, other studies have reported that the supervised exercise therapy programs have an impact on the quality of life and have improved the quality of life. So they could relate that with the intermittent negative pressure. There were no physical activity. There is no social interactions with other patients or other people. So that's why the quality of life has not been improved. So in conclusion, the treatment of intermittent claudication with the lower extremity intermittent negative pressure for 1 hour twice daily for 12 weeks increased the pain-free walking distance in the treatment group who received negative 40 millimeter mercury of intermediate negative pressure, compared with the control group who received negative 10 millimeter mercury of intermediate negative pressure. A second conclusion is that patients with the more systemic diseases, thus patients who presented at the beginning of the pain-free walking distance of less than 200 meters, a significant increase has been occurred in both pain-free walking distance and the maximum walking distance compared with the sham treatment group. Thank you so much.
Thank you, Mohamed.
Thank you.
Any question? Mohamed, do you think, in fact, it is a failed experiment, or do you think that there are any promising data in this study?
I think that it's a really good study as a non-surgical option for those patients. I think the results it's good for the patients who presented less than 200 meters at the beginning. So especially the patients who are really sick. So maybe we can give them this option before the surgery. So I think it's a good study. It's a randomized.
So you think that the subgroup of patients with the main impairment of the walking distance, or inferior to 200 meters, should be investigated by another trial to see if we can obtain an improvement, a significant improvement in this group of patients. Is correct?
Exactly.
Okay.
I think especially in the patient with severe disease, with walking distance less than 200 meters, without easy surgical solution can be very interesting. We have some patients that had already some failure of revascularization, and they have got a walking distance less than 200 meters. And you have to make this bypass to solve the problem. Probably this patient can have some results from this treatment.
I should make some criticism about not the presentation, which was very good, but about the study. First, the primary outcome is pain, so it's pretty subjective to assess pain. First. Secondly, in the study, I don't see any improvement about quality of life. And when you improve the distance by 40, 50 meters, I don't think that it could improve the quality of life. My opinion is the main limit is improvement of the walking distance. You can improve the quality of life because it's so short distance. Thank you, Mohamed.
Merci beaucoup, chef.